Well, I have 9 o'clock and we always like to start promptly. So good morning and thank you for attending the Telemedicine Echo of the Heartland Telehealth Resource Center, which is also known as the HTRC, and Missouri Telehealth Network, which is also known as MTN. We are offering this Echo for providers in Missouri, Kansas, and Oklahoma, and we'll address topics including technical, operations, clinical, legal, and regulatory, and evaluation. So we want this Echo to help you in your telemedicine programs. I'm Jeanine Gracie, Project Director for the Heartland Telehealth Resource Center, and I have the privilege to moderate these sessions. And I also want to give a shout out to all healthcare providers joining us this morning. We want to thank you for being on the front lines, and please know that we appreciate you and your efforts. Before we get started, I would like to ask everyone on this Echo to rename your Echo screen name to show your first and last name, your title, organization, and state. Please right click on your picture and then click rename, and then you'll be able to do that. So I'll give you a couple of minutes to get that started. So one more time, just right click on your picture and then click rename and give us your first, last name, your title, organization, and especially what state you're in. We'd like to know the state. All right, while you're doing that, we'll have the hub team introduce themselves so that you are more familiar with who our hub team is. Karen, would you like to introduce yourself?
Hi, everybody. My name is Karen Edison. I'm the Senior Medical Director of the Missouri Telehealth Network and our Show Me Echo program. And I've done teledermatology for 26 years. So I'm happy to be here. I am in a park and my internet's a little shaky, so sometimes I may be turning off my video screen, but no, I'm here and I'm present.
Thank you, Karen. That's great.
That's just a little tip. If your internet's a little shaky, if you turn off your video, although we want you to keep your videos on, but if you turn off your video, then you'll be able to hear better. So
great. Thank you, Karen. We appreciate that tip. All right, Kristen.
I don't think she's logged on yet.
Okay, we'll keep going. Evelyn Nelson.
Morning, everyone. It's great to see everyone online. I'm Evelyn Nelson. I'm the lead for the Heartland Telehealth Resource Center, and then also a telepsychologist for almost 20 years.
Thank you, Evelyn. Rachel, would you introduce yourself?
Good morning. I'm Rachel Mutro with the Missouri Telehealth Network and Show Me Echo program, and also the Heartland Telehealth Resource Center. Welcome.
Robert.
Hi, I'm Robert Stiles. I'm with the Katy School of Medicine. I'm a program manager and work with a variety of telehealth programs, including the Heartland Telehealth Resource Center.
Thank you. Heather?
Good morning, everyone. My name is Heather Hagan. I'm with OSU Telehealth. I'm a telehealth analyst.
Excellent. Thanks so much. And Tim?
Good morning. I'm Tim Davis with OSU Center for Health Sciences in Tulsa, telehealth manager here and the HTRC representative for Oklahoma.
Excellent. Thank you. So that is your hub team, and that's your expert team that will try to answer your questions as we move through this Echo. Normally on Echoes, we introduce the participants, but since we have over 50 people joining today, we would certainly like to do introductions in a different way. So if you have not done this already, please put into the chat your name and your organization, your location, including your state. If you would do that now, that would be great. And phone participants, if I don't know if you are able to do that on the chat as well. If you're just joining by phone, you're not going to be able to do that. So let me look and see how many phone participants we might have. Looks like one. So with the phone participant, please introduce themselves. 405-919.
Hi, this is Candace Shaw. I'm in Oklahoma, formerly with the Heartland Telehealth Resource Center as the Oklahoma advocate. I'm now just working as an independent consultant.
Oh, it's so good to have you online, Candace. You can run, but you can't hide. So thank you for introducing yourself.
You bet.
That's
Sorry,
great.
I'm on my phone because I'm traveling. So.
Okay, that's great. Thank you so much. So as you continue to introduce yourself in the chat guide, I want to go over a few things about ECHO. So actually today, for a more collegial environment, we are going to use first names only. So, you know, feel free to just use first names, don't have to use titles. We want this to be an environment where you feel comfortable asking questions. Please be conscious of any confidential or protected health information. I don't think we'll have any of that come up today in this type of ECHO, but in case, I just need to make that announcement. Raise your hand if you desire to speak. I'll keep scrolling through, and then also you can ask questions in the chat room. Now, Joe Kingsbury has agreed to name himself Ask Joe Kingsbury. And so if you would like to ask a question, Joe is going to try to field those questions as quickly as he can. If you don't feel like doing that during the ECHO. So please ask Joe Kingsbury, find that in the chat room, and you will be able to ask those questions. Thank you for that, Joe. Please keep your microphone on mute until you're ready to speak. That just helps with all of the background noise. So you all are doing a great job with that. And also, before you ask a question during the ECHO, if you don't want to do the chat part, you can do that by announcing your name first and then asking the question. This presentation will be available on Box, and the value of ECHO is in the cases. So please volunteer a case. If you haven't done that today, then think about any kind of questions or problem that you have run into while setting up telemedicine, or you have questions about how you implement and move on. And so please do that in a case, and we will do that the next time. Our team will put the case recommendations in Box for everyone to access. So at this time, we are going to go ahead and have Robert Stiles give a didactic presentation on some regulatory and just the regulations that have been coming out fast and furious. It's been so difficult to keep up, but Robert is a rock star when it comes to this, and he has some great information for you. So Robert Stiles from the University of Kansas Medical Center, the ECHO is all yours right now.
Great. Hi, everyone. I'm pleased to be with you today. And let's start with, and Jeanine, if you can tell me, can you all see my screen?
Yeah, we can see it.
Great. So I'm really pleased to be here today. Just to kind of start, let me see if I can get rid of the picture so I can actually read my slides. There we go. So the objective for today is to really understand the policy changes and the waivers that have been made by the Center for Medicare and Medicaid Services to respond to COVID-19. We will talk at the end very briefly about the individual states as what they're doing, especially some of the waivers that they've asked for from the federal government, how those impact Medicaid in the states. But we'll spend most of our time on CMS. As most of you know, ever since COVID-19 began, really beginning in early March, there have been a series of waivers and other actions that have been taken to try to help make it more possible to respond to COVID-19, and especially with a number of changes related to telehealth. So my background, I spent 10 years at the Kansas Department of Health and Environment. I was the director of the primary care office there, worked very closely with legislative issues, regulations, policy changes, statute, and then with the federal cooperative agreement, working closely with HRSA and other federal entities. After that, I spent 8 years providing local health services in both Kansas and Missouri. And so kind of have hopefully that practical idea of what matters at the local level and what's going to be important to understand. So as of this morning, these documents and what we're going to talk about are up to date. I spent a lot of time this weekend because on the 9th, both Kansas and the federal CMS put a lot of updated documents, and specifically some stuff related to federally qualified health centers and RHCs that we'll talk about today. So what's really happened is under the state of emergency that's been declared nationally, there is the opportunity for waivers to occur. And there's Section 1135 waivers under the Social Security Act. And it temporarily allows Medicare to modify or waive certain Medicare, Medicaid CHIP, or HIPAA requirements. So what's happened is there have been both blanket waivers as well as state-specific waivers. So the blanket waivers are some of the more, in my opinion, aggressive and broad waivers that have happened. And then all three states, Missouri, Kansas, and Oklahoma, have applied for individual state-specific waivers, and we'll talk about those. So the first sort of set of blanket waivers that occurred were what I think it was March 15th, but I may be wrong on the date. I should have put it here. But basically, the first things that Medicare came out with were out-of-state providers were allowed. So most of us have seen our states allowing that now. Allows state Medicaid programs and Medicare to temporarily bill non-enrolled providers. So somebody that may be enrolled in another state or even not enrolled at all. It allows states to apply for individual applications for further waivers, which those are the state-specific 1135 waivers. It removed the rural requirement for Medicare telehealth. So that was a huge change, right? There used to be specific rules on where telehealth could be used in the Medicare program, and now it can be used in urban areas, it can be used anywhere. It also said no longer do you have to have a previously established relationship, so you can now see new patients through telehealth. And then it allows phones with audio video and some audio only billable visits. So there is a specific set of codes, we'll talk about that in a minute, that you can talk to someone specifically on the telephone with. So, you know, in those instances where someone may not have a phone with video capability, it still allows you to see a patient for certain things and to bill for those services. One thing that's really important, I'm not a billing expert. So we'll talk a little bit about billing today, but reimbursement is another issue that is sort of unclear. And one thing that is interesting is it's going to be interesting to see kind of what the reimbursement, how that comes across, especially for those telephone only payments. So on March 30th, they rolled out a bunch more. This was the big dump of rules and blanket waivers. So it really allowed for an expansion in the type of services that were allowed through telehealth. It added virtual check-ins, e-visits, and remote patient monitoring. It expanded sort of who could do those and what could happen. I'm gonna hit virtual check-ins and e-visit in their own slide because there's been a lot of confusion about that, and I wanna make sure it's clear what those are. The biggest thing to know is it has to be patient initiated. So that's not a substitute for some of the other ways you might want to provide telehealth services. It added additional providers that are allowed to provide telehealth and allows in different environments. It allows provision of telehealth to the home. And then also expanded telehealth for home health, hospice, inpatient rehab, hospice twice, end-stage renal disease, nursing and assisted living facilities. And it allows FQHCs and rural health clinics to act as home health agencies. We'll spend a little time on FQHCs and rural health clinics because there's some broad changes that are happening that haven't quite happened yet that everyone should be aware of related to the CARES Act. And then it really expanded the ability of nurse practitioners, physicians, assistants, and other non-physician providers. It really loosened some of the supervision requirements and specifically for RHCs and FQHCs, some of the requirements that they had in that area. Allows for the telesupervision of patients by physicians, as well as telesupervision by the teaching physician for medical residents. And then finally, allowed Medicare Advantage plans to expand telehealth outside of the time that they would normally expand their benefits. So those are the big things. So on April 9th, there was an update for FQHCs and RHCs with these blanket waivers. It allows, it waives the requirement that an RHC or an FQHC have a nurse practitioner, PA, or certified nurse midwife at least 50% of the time. And it also modifies the requirement that physicians provide medical supervision of healthcare staff, but that is only in respect to supervision of nurse practitioners. So here again, we see sort of an expansion, and I know everybody hates the term, for physician extenders or mid-levels. We just don't have a good term for it, but specifically and only for nurse practitioners. And then finally, it's really important to know that in some of the states, Medicaid is already allowing FQHCs and RHCs to bill the distant site fee, but that's not yet in Medicare. So there is an interim final rule that has been put out by CMS related to the CARES Act and some of the changes that it made. And this is one of the changes in the CARES Act. The CARES Act was the, people thought about it as a stimulus bill, but it does have quite a lot of money in it. And we'll be talking about that in a couple of weeks in terms of opportunities there specifically related to telehealth. Those of you who hopefully have been aware that USAC, which many of you are familiar with, is one of the routes, and there's going to be quite a bit of funding for telehealth equipment as well as the provision of telehealth services, broadband, and things like that. But Medicare has not yet clarified the billing process or from what date that FQHCs and RHCs will be able to bill the distant site fee. What they have made clear is it will not be cost-based or PPS. It will be a fee-for-service payment. And it specifically states that they cannot, in the legislation, that they cannot base it on cost. So you know that much. So CMS has done a great job of having a great website where they talk about all the blanket waivers, they talk about the 1130 waivers. They also provided specific provider sheets by provider type. It's really helpful if you're a particular provider type. It's a little difficult sometimes to try to understand all the changes related to telehealth when they're in various of these documents. But the ones that are in red are the ones that have the most, probably the most practical or most content related to general provision of telehealth. So physicians and other practitioners, hospitals, teaching hospitals, rural health clinics, and FQHCs. And then if you are one of the other provider types, of course, it's important to read through the document, the fact sheet that is available for that provider type. So in addition, CMS is making other waivers and there are other approvals, and I wrote approval wrong. In addition, so accelerated advance payments, and that's something I know through practical experience and from talking to friends that work in healthcare. We're all trying to be prepared for, sort of the onslaught and what may be happening if we do end up not kind of controlling things and have a huge amount of COVID in an area. So we know that many, we've seen patient visits go down. We've seen, and so many clinics have had a lot of financial issues. And so they really have expanded, accelerated, and advanced payment process. And there's really good information on how to apply for that and how to do that. But I would recommend anybody looking at financial issues to look into that. And then it also removes some, or basically, and it's very important to understand the difference between the waivers and sort of what I consider, they're sort of ignoring the law or willing to provide, some, they're not enforcing, I guess is a better way of saying that. So one of the places that they're not enforcing is Stark Law, physician self-referral. They have very specific areas where that physician self-referral rules are going to be sort of looked at, not enforced. So it's important to kind of look at what those are. So in addition, Missouri, Kansas, and Oklahoma have submitted and had individual state 1135 waivers approved for their states. And so those are specific to their states. And the examples and really what most of those include are things like prior authorization for services, permitting out-of-state providers to provide care in their states, which all three states are allowing, enrollment and revalidation requirements for providers. And then there is another area, 1915C waivers, and those are really related to those home and community-based services waivers. So Kansas and Oklahoma have submitted and have waivers related to sort of their waiver population. Missouri has not. So, and what kind of they've gotten approved would be in what's called their Appendix K documents, and those are available on the CMS website as well. For any of these documents, it's important to know that we do have state fact sheets as well as a federal fact sheet available on the Heartland Telehealth Resource Center website that is under our COVID-19 section. And all of the links are available on that in those documents for any of these things. So the best place to go if you want to figure out where to get any of these documents, because it's often hard to know where, and even a search on Google may not get you where you're wanting to go. But if you look at those documents, for every single item that we're talking about today, there is a link, a web link to the document or to where that document is. So other federal actions, and this gets into the idea of waiver versus non-enforcement. HIPAA did not go away, but HIPAA, they're providing enforcement discretion for non-HIPAA compliant. And it's important to understand that they use the term good faith actions. You can't just do anything. I was talking to Dr. Nelson, who's a clinical psychologist yesterday, and we were talking about this, and you can't be in a park providing telehealth services. That's not good faith, right? Where the whole world can hear. But this is really trying to allow, in those instances where a HIPAA compliant method isn't available, allowing that you can provide services and that they're going to look the other way if it violates HIPAA, as long as it's a good faith action to provide care to that population. So similarly, controlled substances with the DEA, they are allowing prescriptions for Schedule 2 through 5 without a previous relationship, and those can be done electronically. So that's important to know, because previously it had to have a relationship. You can also call emergency Schedule 2 or just call in Schedule 3 through 5. And then anti-kickback, the Office of Inspector General has said that this is more of a non-enforcement, not a waiver, that they're not going to subject physicians and other practitioners to administrative sanctions for arrangements that reduce the cost for a patient. So it's kind of important to understand the idea that this is not a waiver. I had a question last week with the Federally Qualified Health Center in Kansas, question about if they waive some fees, are they going to have to really change their whole fee schedule and everything else? I would say in a situation like this where you're trying to do what's best for the patient, it's not as big of a requirement to have sort of every single item changed or to waive all fees when providing telehealth. It's just about making it more practical and more possible in those situations where it would be hard to collect a fee or you wouldn't be able to provide the service because of issues with fees, that they're going to understand that normally you couldn't because it's an anti-kickback issue, reduce whatever someone, their copay or other requirements under Medicare, that they'll look the other way if you're trying to do what's best for the patient or just try to deliver those services. So I'm not going to go through this, but the easiest thing, and this is on the HTRC website, to really understand, this is Medicare's explanation, this is CMS's explanation. They did a Dear Clinician letter where they kind of went through and they had a section on telehealth and they said, here in their best plain language, are what they're allowing related to telehealth and the changes that they've made. So these slides are going to be available. We'll be, with the ECHO as well as on the HTRC website. So if you really want to kind of understand what Medicare is saying, hey, this is what we're doing with telehealth, this is the best place to look. So, So I did want to go into virtual check-ins and e-visits because there's a lot of confusion and people may not have used those before and they see the expansion of provider types and methods. So virtual check-in is for a newer established Medicare patient. It's a brief communication for wherever the patient is located. It can be their home. It can be synchronous or real-time, right? So it's store and forward or real-time. It can be over telephone or through video or image. It has to be initiated by the patient. So that's very important. But they do point out that practitioners can let patients know that they can ask for this. But this is not a way to provide a clinical visit, another method. It's a really specific approach and really is part of care management for a patient, not a way to initiate care with the patient. E-visits have to use your patient portal. It can be from the patient's home, newer established patient, non-face-to-face, has to be patient initiated. They describe it as exchanges with the practitioner online through the patient portal, and again, has to be initiated by the patient. So e-visits, it's very interesting because they've expanded the type of practitioners from including occupational therapy, clinical psychologists, and some others where e-visits can happen. But just know that this is not a way to kind of provide telehealth visits using those types of practitioners. It's a specific type of interaction. So place of service is very complicated, and the states have made it more complicated. And Medicare has been trying, but they haven't really kind of got it all sorted out. So per the Medicare Final Interim Rule, and the Center for Connected Health Policy is sort of the National Telehealth Resource Center related to policy. So I'm using their description because they're smarter than I am, and they certainly know billing better than I am, because it is very confusing. So per the rule, providers are allowed to report the place of service code that would have been reported had you done it in person, right? So this is different than telehealth before, where there were specific modifiers. And then they're just asking you to use the modifier 95 to indicate that it took place through telehealth. So you can, right? They're saying you can bill it as if it happened in person. But the way you've done telehealth normally, and where the confusion is, you can still use the place of service code 02, which is the home, and it would pay the facility rate previously. So some people are saying that if you were previously a telehealth provider, you should continue to do it in the old way using code 02. Others are saying it's your choice. I don't know the answer, and I'm always honest when I don't know the answer. So this is the best I can provide on that issue. And then each state Medicaid program has its own requirements for place of service. So Kansas is very, very clear, even though they've been very, very confusing, because they keep saying 12 when talking about services in the home. But then they later say in all these documents, all these KMAP documents, but when you're billing for telehealth specifically, it needs to be place of service 02. And they even really lay out that 12 is only when the provider actually goes to the patient's home. So I wish they quit describing home as place of service 12 and then tell you to bill 02. But the answer is bill 02. If you're doing telehealth, you're not in the provider's not in the patient's home, it's 02. Missouri tells you to bill it as if it happened in person. So that's similar to what's kind of happening with the Medicare final interim rule. And then Oklahoma has billing instructions for telehealth and telephone available through their provider reimbursement notice 2020-03. And I don't go into more detail because I found them very confusing. So maybe someone who's more of an expert in Oklahoma Medicaid can kind of explain how that's supposed to happen. Really quick, Missouri Medicaid. Missouri did do a state 1135 waiver. It allows Missouri to enroll providers from other states, suspend prior authorizations and medical necessity, and extend pre-existing prior auths, and the timeline for the fair hearing process. And then Missouri HealthNet is putting most of their information out through what they call their provider hot tips. So they are allowing new patients through telehealth, waiving the copayment in Medicaid for telehealth, quarantining providers from other states, as long as they're licensed state where they practice, can provide telehealth, can use telephone, but you can't bill the originating site fee of the home, including telebehavioral for telephone. There's no separate telehealth fee schedule. Hospitals and RCs may service distant sites. So, even though, so Missouri and Kansas are a little ahead of CMS, and so CARES Act allows it, so they're allowing it even though CMS hasn't really implemented that yet for Medicare. It clarifies that DA guidance is allowed in Missouri, expedites provider enrollment. Surprisingly, allows you to do well-child EPSDT visits through telehealth. I think that's interesting. Good luck. And it tells you to continue to bill primary insurance, even though Medicaid may be billing better and easier when it relates to telehealth. You still have to bill the primary insurance, whether it's Medicare or a private payer first. So Kansas, Governor's Executive Order 2008, although she just put out one 2019 that I'm adding to our document. But this is the one specifically related to telehealth. It says an in-person exam, not including for controlled substances, is not required. Out-of-state physicians have to provide telehealth. It's very important on that one. You have to inform the Board of Healing Arts of Kansas, and they have a specific document you have to fill out on their website. I hate to tell you, it asks for a picture and references, and but still, God bless, they're trying. And it does allow the Board of Healing Arts, and only the Board of Healing Arts, to provide emergency licenses for those professions it regulates. So this doesn't impact Board of Behavioral Sciences, it doesn't impact Board of Nursing or some of the other boards. 1135 waiver, very similar to Missouri's, very similar to every state, because Medicare was very clear on, CMS was very clear on what you could ask for. Prior authorization, provisionally enrolled providers, fair hearing, I think we've heard that before. And then Kansas is mainly using KMAP bulletins, although the KDADS, the Kansas Department for Aging Disability Service website, has bulletins as well if you're a home and community-based services waiver provider or a mental health provider or a substance use provider. KDADS has documents detailing how to do that and what's being changed and how they're extending telehealth in those areas. But really, for general providers in Kansas, the KMAP bulletins are most important. A couple new ones this morning, so I didn't update this, but they're really just new codes and brain injury waiver in some areas that most people probably don't work with. So expanded codes, equivalent payment for telehealth services, that came out very early. Adam Proffitt, the state Medicaid director, put out a bulletin 245, very clearly saying that telehealth services would be paid the same as in-person services. Kansas has created teledental codes. Missouri already had teledentistry. Kansas didn't. some stuff on MCO and out-of-network providers and how the MCO process works, health homes, and then the One Care program. And Kansas does very specifically allow rural health clinics and FQHCs to bill the distance site fee for Medicaid, and that's in probably what I call the big one. The big KMAP bulletin is 246, and that's where that's detailed. And then, like I said, KDADS has also documents if you're providing behavioral waiver services. Their website has that resource. Oklahoma did a governor's declaration on April 7th. Wants to increase by April 15th the ability to enroll the number of medical providers in the state, reduces the supervisory requirements of non-physicians, allows a physician to supervise as many PAs, CRNAs, or NPs as they want. There's no limit on that now, and you can supervise using remote or telephone. And telemedicine is allowed for new patients, but not for those being prescribed opiates. So all the rules in relation to controlled substances are related to not allowing new patients are still enforced in Oklahoma. And then Oklahoma did 1135 waiver as well, provisionally enrolling providers. I think we've heard a lot of this before. Alternative settings allows provision of services in alternative settings. That's a little new, not in the other two states. Timeline for fair hearing, and some prior authorizations and some other things. So finally, really want to get into CARES, although we'll be talking about that in a couple of weeks, but there's some things that are important related to the provision of telehealth that I wanted to make sure we hit today. It does have a lot of the stimulus and policy, a lot of the policy changes we've talked about today are allowed by the CARES Act, HR 60. The initial stimulus and policy changes, there was a very early stimulus that was added on to something else, HR 6074. It had some things in it that weren't quite right, and so CARES is fixing some of those things. Like I said, it's the stimulus bill. That's where a lot of the money coming out to try to deal with the situation as well as to kind of restart the economy are in there, but it also has some policy and regulation changes. So a lot of it kind of goes into policy changes we outlined previously. And like I said, well, the big thing is it does let FQHCs and RHCs to be distance sites and bill a distance site fee, and it's not yet implemented for Medicare. They're in the process. They have the interim final rule, but they haven't really rolled that out, and there's no documentation sort of giving approval for you to do that. And then it's got a lot of new funding for various sectors and projects related to telehealth, and we'll cover a lot of that in the next session. But do want to make sure everybody who's interested in telehealth equipment or broadband or some of the other things to be very aware that they're already rolling some of that money out and that process out of application. And so you need to really be aware of that. And if you want to kind of know where to go or what to look at, please contact the HTRC and we'll be able to help you with that. So big resource is the National Consortium of Telehealth Resource Centers. I would definitely tell people to look at the Center for Connected Health Policy. They do a great job on health policy, and they're really responding and looking at especially federal changes and rules related to COVID-19. And then for technical assistance for Missouri, Oklahoma, or Kansas, the Heartland Telehealth Resource Center is hopefully your resource. And we have on our website specific information for COVID-19 policy and regulations, including very detailed, well, hopefully not too detailed, but 8 to 9 page documents that go over everything I talked about today. There's one on federal, there's one on Missouri, there's one on Kansas and Oklahoma. The updated Kansas, Missouri, and Oklahoma will be up later today. There were just some changes that I had to make this morning. So I really appreciate it. I'm going to unstop my share, and hopefully I've been clear and as clear as I can be. Policy is complicated. So thank you, everyone.
Thank you, Robert. Excellent information, a lot of information. And so we're now going to open up the queue for questions. So if you have a question, please unmute yourself and introduce yourself and ask the question.
Jeanine, there was a question that was sent to us from Tasha Clark in Kansas City regarding Missouri Medicaid. Tasha, if you'd like to unmute yourself, you can ask your question.
Hi, I had to turn off my video. My audio was not working very well. Can you hear me okay? Okay, so I think you said that in Missouri for Medicaid, you could bill telehealth as if done in person, but then there was something that was stated after that saying that that could only be done if the person, it was not allowed if the person was in their home. So I'm a little confused. So Missouri Medicaid, you can bill as if in person? Go ahead.
Absolutely. Sorry, no, I'm not sure what I said, but the second statement is not correct. They can be in their home. So
Okay.
The guidance that Missouri has given, it's on the Medicaid hot tips. It very clearly just blatantly says there's no separate fee schedule for telehealth. It's paid the same as if in person. So,
Okay.
and Missouri absolutely allows to the home. So,
Thank you. Good.
All right, any other questions for Robert? He's a great resource, so get your questions answered now.
I currently have nothing in the queue.
Thanks, Joe.
well, clearly I've either been very clear or very confusing. So we'll hope for clear.
Just a lot of information, and remember, all of this will be in the box that you can access and read through and digest. So, because I do know that this can be confusing, so good job.
And I would recommend anyone to read both the federal policy statement, and we'll have those in the box, as well as the policy overview for your state. If it's been done, it's in there. We keep that up to date every day. So it's going to have, like I said, references to exactly where to read the actual documents and a synopsis of kind of what the change is.
Hey, Robert, there was a question in the chat. It says, have these policies for Missouri Medicaid been applied to PT, OT, and speech therapies? And that is from Ann Simon.
I'll have to look more closely. Those are, the types of providers and expansion providers has really varied. I'm not sure, to be really honest, but let me get back to you. I'll try to email you after this, get your email from and get you a good answer to that. I believe that their intent is to allow those things, but I don't recall any hot tip that specifically talks about those professions. CMS, on the other hand, has very clearly defined those professions and what they can do and how services they can provide have been expanded through telehealth. Kansas has as well. They have a whole bunch of stuff today up on brain injury waiver with speech therapy, for example. They're getting very specific. Missouri has kind of taken the approach, and I appreciate it, but it sometimes gets a little confusing for this reason of being very broad and just basically telling people to do it. Kansas and Oklahoma, on the other hand, are, that's why every day there's a new bulletin from KMAP and Kansas Medicaid, for example, because they're getting into the weeds, and I guess that's great. And I appreciate that Missouri is really trying hard to just be very general and say, hey, do it. But you get into questions like this, and I want to make sure that I understand, and I've very clearly reviewed everything before I give an answer.
This is Rachel from Missouri Telehealth Network. I would add that in Missouri, we allow any licensed provider to provide telehealth services, and that also counts for under MoHealthNet or Missouri Medicaid.
So I think that's the answer. I mean, it really is. I guess I would say I really love that Missouri's wide open, right? They're saying, hey, we don't need all these special codes. Just bill it as if you're doing it in person, and we're going to guarantee you'll get paid as if it was in person. So in some ways, Missouri's, the most ahead, or the most, really willing to say, hey, just get the care done. And I really appreciate that. That's why there's not all these huge documents like you see in Oklahoma and Kansas. I mean, they're putting it out mainly through these hot tips on their website, which are just brief paragraphs. So really, I'm proud of all three states. I'm proud of our country because we've really responded quickly and are really doing a great job. But sometimes it gets a little hard when there's not a short or a very clear answer to some things.
Right, Candace Shaw.
Hi, I have a quick question and follow up to that, Rachel. When your state statute specifies that those additional areas are not able to provide services, have you seen your governor come forward with a waiver of that, or how do you balance that when the state statute actually is adverse to what is happening?
Candace, I'm not sure which statute you're referring to, but 2 years ago, we had sort of this, I would say, power struggle between the legislature and MoHealthNet regarding writing some of the restrictive rules. And what ended up happening is in state statute, I can't remember the bill number, but it was Representative Barnes, came out and basically said, guess what, MoHealthNet, you're not allowed to write any more rules. You have to go by the statute. And so that what the statute said was basically any licensed provider can do telemedicine for things that they do in person. And what's, you know, if it's within their scope of practice, then they can do it. So really, and so then what happened with Medicaid was they said, we rescind all previous restrictions. We're only going by what the statute said. So, you know, it was kind of a weird time, but what ended up happening is it's just wide open.
Okay, thank you.
Yeah.
We do have a question from Jerry Wilms here in Missouri. Jerry, if you'd like to unmute, you can ask your question directly.
Yes, I apologize. I'm at home and my wife just opened the garage door. So if you're hearing that weird noise, that's what that is. But my question is about people under private carriers, non-Medicare, non-Medicaid. How does that work within the times we're in, or is that subsumed somehow within the CMS and the Medicaid guidelines, or is that a whole different animal?
It's a whole different animal. Each private payer is going to have their own set of rules. There are a few things, the policy changes that CMS has made that the private payers, of course, are going to have to respect. For example, the DEA requirements and HIPAA, because private payers don't enforce HIPAA, right? But I say that now and then I take it back, because Kansas has done something very clear, which is if you're doing televideo in Kansas, Kansas Medicaid will not pay you unless it's HIPAA compliant. So, you know, I really point that out a lot to the Kansas people, that you're not going to get in trouble, right? You're not going to have an enforcement action against you under HIPAA by the Office of Inspector General, but you're not going to get paid. So in a desperate situation, use a non-HIPAA compliant, you're not going to get in trouble, but don't bill for it or you're committing fraud. And so it's similar that each private payer, some states are doing really well in terms of trying to stay on top of that. I've been very impressed with the Office of the Secretary, Vicki Schmidt in Kansas, for example, who has contacted all the licensed healthcare provider, insurance companies in the state, and has links on her website to each of them and what their guidance is on response to COVID-19. I haven't seen that in Missouri and Oklahoma. It may exist, but really you have to go with each private payer and what their rules are going to be, because it's CMS policy or state Medicaid policy is not going to necessarily be the same. The only place that is going to be the same is the managed care organizations in each state have to, of course, follow what Medicaid says, because they're, you know, contracted to Medicaid.
Thank you.
Jerry, I would just add to that a couple things. First of all, Missouri does have a parity law, and that parity law tells private payers that they have to pay for telemedicine if they would have paid for that service in person. And it also says they have to pay the same amount as they would have paid in person. Now, specifically to that law only covers private insurers who are covered by the Missouri Department of Insurance. So the biggest exclusion to that rule or that law is self-pay or self-insured policies. So I work at the University of Missouri. We are self-insured. So that parity law does not cover the policies of the University of Missouri or, for example, the state of Missouri. Does that make sense?
Yep.
Okay.
Thanks.
Next, we have a question from Mac Taylor in Southeast Missouri regarding equipment and infrastructure. Mac, if you'd like to unmute, you can ask your question directly.
Thanks, Joe. So I run a dental part with our network, but is there a good place to look, or is there a list of items that would build a good foundation for a telemed program? We're currently in the process of writing a grant application and trying to implement a program for our own network here. And we're actually going to have a call on it today. So I was going to see if there was some place I could direct our corporate group to look as far as, you know, computer systems, video capture, that kind of thing. So I'm sorry.
I can probably take this. Hi, Mac. Rachel from the Missouri Telehealth Network. There are a couple things here because we are funded by HRSA. We are not going to recommend any one equipment vendor or over another. However, there are lots of private consultants out there who will help you, who can help you weed through some of the different vendors. We do have a national telehealth resource center dedicated to technology though. And their website, we can have somebody put it up in the chat. It's TTAC, the Telehealth Technology Assessment Center. And they have lots of documentation on their website about the different vendors that they have looked specifically at different equipment. So I know you run the dental group down there in the southeast part of the state, but if you're looking not just at dental, but at different kinds of telehealth programming for primary care or specialty care, there's just a whole lot out there right now. And you know, offline, I can go through a list of the different vendors, just that I can't recommend any of them, but I can go through them with you and talk about some of the different attributes. But you know, there's been such a consolidation of technology vendors over the past 5 years in the telehealth world that I think that this might be a good time. If you haven't talked specifically to a consultant, it might be a good way to go on that. Again, I can talk through some of the things with you, but I can't make any specific recommendations.
Sure, thank you.
Any other questions?
Yes, we have a question from Ann Simon in St. Louis. Ann, if you'd like to unmute, you can ask your question directly.
Yeah, hi. So I'm a social worker at Mercy Hospital St. Louis in Missouri, and we have done a lot of legwork the last few weeks getting ahead of the game with speech, OT, and PT, particularly pediatric coverage. Rachel, I'm really curious about the parity law that you mentioned. You said specifically plans that are covered by the Department of Insurance that are not self-funded, and we are getting some conflicting information in all of our insurance checks with one particular group. So I'm curious, do you have a resource of where I can find more about that parity law?
I do. I will find the link to that and send it out. I'll put it in box and make sure I have it, but Ann, I'll write it down. I'll get your email too, and I'll send it directly to you.
Oh, thank you so much, Rachel. That would really help us out.
No problem.
Great question.
I would just add for those in Kansas, so Kansas does have a parity law, but it's sort of gotten held up by some abortion items, and so not totally enforced, but there absolutely is a law. There's just been a stay related to some abortion language in it. So hopefully that'll get cleared up, because I'd love to have what Missouri has there.
And I will speak for Oklahoma. We have parity law, but it is not equal pay specific. It is just that they have to pay.
All right, any other questions?
I see a hand for Chelsea Johnson.
Hi, yes, thank you. Chelsea Johnson. I'm at Children's Mercy Hospital in Kansas City. It's a little off on left field, but I haven't heard any discussion about practices in hospitals, medical malpractice, discussions about whether they're covering these telehealth changes during this time, if they are covering when other states say that you can practice in their state, if you previously weren't practicing telehealth and now you are. Are these companies also coming to the table and saying, yes, we're going to cover? Are they not wanting to cover in case that this is something that is dealt with, you know, months and years later about med-mal? Thank you.
I would say that that is sort of like private insurance as well, private medical insurance, that you're going to have to talk to your malpractice provider. Those that are federally qualified health centers and have that's my area of experience, you know, so you're covered by the Federal Tort Claims Act. You know, your emergency plan is what would matter. And so if you have alternate sites and other things in your emergency plan, then it's going to be covered under the Federal Tort Claims Act as well. But I would say if you had a lawsuit, for those of you under the Tort Claims Act, that relates to services provided in alternate location or through alternate means due to the emergency declaration, just make sure that that's in your plan, because as somebody who's had lawsuits, I used to employ OBGYNs who get sued, unfortunately, quite often. You know, it's important to make sure that you're following the rules for tort claims protection. And I used to manage the Kansas Tort Claims Act related to the Charitable Healthcare Provider Program. And I would say it's a broader act. And so from my previous experience, I would tell you, those of you who are using the Kansas Tort Claims Act, specifically under the Charitable Healthcare Provider Program, you would have coverage as well. But you're going to have to talk to your individual private malpractice provider.
Any other questions, Joe?
I don't have any on my queue.
I'm looking for some raised hands, not seeing any right now.
Jeanine, I can offer something just for everybody's information. So here at the Missouri Telehealth Network, we've been able to partner with the Missouri Department of Health and Senior Services and the Missouri Research and Education Network to offer free Zoom licenses to particularly non-for-profit healthcare organizations that would like to use those Zoom licenses to see patients or provide administrative meetings or trainings or really anything related to doing work virtually during this crisis. So if anyone on the call is interested or needs that for your organization, please go to either the Missouri Telehealth Network website or showmeecho.org, and you can figure out how to apply for one of those or more of those licenses.
And this is Karen. I would also add that there are many of us who've done telehealth for a very, very long time. And so if you have providers or if you are a provider that hasn't done it before and you'd like to talk about tips and tricks for doing it successfully, I'd like to offer myself up as a resource for that.
Thank you, Karen. That's an excellent resource. Absolutely. Evelyn?
Jeanine, I'd just like to encourage folks with our Heartland Telehealth Resource Center. I know you're a great contact that helps across our 3 states. So if folks are excited and have deeper dive questions after today and the ongoing ECHO, just know that that's our job to across all 3 states with Rachel and Tim and your and everybody's expertise. So just feel like folks can call the Heartland number, and then we'll help connect you with the folks in the state.
Absolutely. Thank you for that. Yeah, please know that we're available. You can check our website. The website has a wealth of information. The National Consortium of Telehealth Resource Centers also has some very good information that you could take a look at. And Rachel, if there's any way you could put that webpage link into the chat, that would be excellent. It's a resource that has a plethora of information, more than you probably want to know. So that is there for you as well. So thank you, and please use our service. We can certainly try to answer your question. If we don't know the answer, we know colleagues all across the nation that can help out with that. So especially the dentist practice that wants to get into some teledentistry, there's some very good information on the web about that, and we can certainly point you to the ones that we have worked with. Great.
Do you have a hand up from Carla Husted?
Sure.
We, my agency, we are not techie people. We're a very small nonprofit hospice, and we did the Zoom license through the Show Me Echo. It was really easy. People should not be intimidated by that, and it's been really, really helpful to us. We have limited space and can't hardly social distance, but it's provided us the contact with each other that's helped us get through this.
That is good to know. Thank you for that feedback. Excellent. Way to go, Missouri. All right. Any other questions? You know, we do not have a case study today since this was our first one, but think about it. If you want to put something down and make that a case study that we can talk about and discuss and help. And the whole idea is for everyone to help each other on this. Sometimes the hub experts may not have, you know, some information that you have. And so we are all in this together, and we thank you so much for joining this ECHO. Please come back next week and learn something else. In the meantime, just stay healthy, stay safe, practice your social distancing as best you can, and we'll see you next week. Thank you.